Yes, doctor, we are live. You can start the session.
Very good evening to every one of you, and a warm welcome to this live webinar by Glaucoma Society of India. So this is a series of webinars we have planned by our masters. We have the presidential masterclass series, and we have international speakers. Then we have the masters in glaucoma series. So we are going to have this program once in a month, and we have our past presidents to give the talks on multiple areas of glaucoma. So we know that our past presidents are they've done a great job in glaucoma all these years. So it is time for us to understand and listen to them with all the rich knowledge that they have. Today we have our panel, Dr. Sood, Dr. Devendra Sood from Delhi. He is our past president. Then we have Dr. Murli Ariga from Swami Eye Clinic. He is the director from Chennai. And then we have Dr. Venkatesh from Pondicherry. He is the chief medical officer. And of course, you are joined by our wonderful secretary, who really supports in every activity of our GSI. And we have our treasurer too. So with this, we'll not take much time. I would request Dr. Murli and Dr. Venkatesh to uh, give a detailed CV of Dr. R.K. sir and Dr. Krishnadar sir. And then we can move on with the topics, and then we can have the panel discussion later. Over to you, Murli.
Thank you, Dr. Satyan. I think it's a wonderful initiative on behalf of the Glaucoma Society of India to organize these webinars and educate members of the Glaucoma Society and on a regular basis. And I think the program schedule looks very interesting, and we all look forward to this. Thanks to the GSI team for starting this. I think we are really starting off with some of the best minds and best experienced glaucomatologists of the country and of the world. And I think it's my real honor and proud privilege to introduce my senior and respected teacher, and of course, none other than Professor Ramakrishnan, who has been who is currently the advisor and head of the Institute of Arvind Eye Hospital at Tirunelveli, and of course, a senior consultant in the glaucoma department. He's held numerous posts in the Arvind Eye Care system. And having joined the Arvind Eye Care system in '87, he has been the CMO of Arvind Teni. He has been chief of glaucoma at Arvind Madurai, and also been chief medical officer and head of glaucoma services in Arvind Tirunelveli for a long stint. And also now is the advisor and head of the Arvind Eye Hospital Tirunelveli. He's been closely associated with many international glaucoma faculty like Professor Alan Robin in Johns Hopkins in Baltimore, and more than 3 decades, and has been involved in various research projects and a principal investigator of very important studies like the mitomycin study and the Arvind Comprehensive Eye Survey. He has held numerous posts as head of institutions and organizations, like has been the president of the Glaucoma Society of India. He has been the president of the Tamil Nadu Ophthalmic Association and also president of the Tirunelveli Ophthalmic Association. He has published a book on the diagnosis and management of glaucoma for ophthalmology students, fellows, and practitioners. A very popular book and still sought after for many of the chapters and references. He also published a book in Tamil on common eye diseases. He's been a postgraduate teacher in ophthalmology and glaucoma, training hundreds of residents, 250 long-term glaucoma fellows, and more than 400 short-term fellows in India and worldwide. He has taught surgery and has been a surgical trainer in various countries, Kenya, Indonesia, China, and various countries. Other than this, many other countries as well. And a very popular teacher and a very popular, most sought-after speaker in various international and national conferences. I don't think there's any conference in glaucoma in which RK has not been present in the last, say, 20, 30 years. You will definitely see him, and he'll never say no unless some other pressing engagements are there. Numerous awards to his credit. innumerable awards. Almost I can see 25 awards in the list of awards he has. I think this is probably a summary of his short curriculum CV, and I think probably he's probably the recent ones have been the Professor Sood Oration at the Glaucoma Society of India's Oration Award, Professor Velayudham's Oration Award, and also the Professor N.N. Sood Lecture Award at the RP Center in All India Institute. Besides the TNOA, Tamil Nadu Ophthalmic Association Lifetime Achievement Award very recently. I think I can go on speaking about RK and his achievements for the last 2-3 decades. I think most of us know him very well, and we all call him RK fondly. I think Dr. RK, I think I will not stand between you and Dr. RK's lecture today. Dr. RK, you're welcome to speak.
Thank you, Murli. RK sir, over to you.
Okay. Thank you, Murli. It's too long introduction. Thank you very much. And dear President Satyan, my dear Manish and Devan Tulli, and panelist Dr. Sood and Dr. Venkatesh and Murli. A warm good evening to all of you and also my co-speaker, Dr. Krishnadas. I have to thank and congratulate the President, Dr. Satyan, for initiating this webinar today, and I am very proud to be the first speaker of this webinar. The topic what I am going to today present is one of the important topics, this comprehensive guide to initial management of a glaucoma patient, because nowadays it's very, very important that glaucoma is not a rare disease, all of you know very well, but most of the time it is overdiagnosed, or sometimes even a glaucoma patient also underdiagnosed. So many things are happening in the recent years because of the invent of so much of diagnostic gadgets, especially OCT and fundus photo and visual field, etc. Of course, I don't have any financial disclosure. Glaucoma, all of you know, is mainly I'm talking about the open angle glaucoma only. All other things will be covered later. And of course, it's a chronic progressive optic nerve, but it's not an acute process, and it's leading to because of the progressive injury to the retinal ganglion cells and their axons, with a specific pattern of optic cupping and visual field defect. Even though there are so many risk factors being described in the pathogenesis of glaucoma, IOP is one of the major risk factors that can be a modifiable risk factor. And of course, this is a very well known fact that to have a demonstrable visual field defect, you should have at least 35 to 40% of the death of the retinal ganglion cells. So earlier you will have a RF defects. This earliest sign, and this occurs earlier than the optic nerve damage and visual field defect. And of course, this is one of the, all of you know very well, I don't want to spend much time on this, because any glaucoma, it will go through 3 stages. One is the undetected stage, and the second one is the asymptomatic disease, and the third one is the functional impairment. First one is very, very difficult. Clinically, you cannot identify. Second one, of course, with the some sort of detectable fundus photo and OCT, we can identify the changes in the retinal nerve layer. And function defect, of course, we have so much of this thing. You have perimetry and other things. Finally, it will go for severe visual field damage, and finally, it will go for blindness. So normal too. This is just a gradual process, not an acute process. That's why a patient with glaucoma is not going to become blind in a week or a month or a year. So it is a chronic progressive disease. And of course, most of you know very well, it's a challenging disease. It's a chronic disease, of course, and of course, most of the times are asymptomatic. We only tell them, the patient, that you are having glaucoma. And of course, lifelong management follow-up is essential, and it cannot be cured, and difficult for patient to realize the benefit of treatment. This I used to tell the patient and also to our fellows and juniors. patient will not appreciate any benefit out of the treatment. That's it. Mainly it will reduce intraocular pressure, but in long run, it will maintain the visual field and it will stabilize the damage of the aortic nerve head. And also most of the patients are affected by the diagnosis of glaucoma itself. And of course, it's one of the important things that can affect the quality of life of the patient. And even with the treatment, sometimes we have seen many cases they will go for blindness. So about 15% of the patients go blind on treatment in their lifetime, and another 26% they will go blind only in due course of time. So the goal of treatment is to preserve enough vision during the patient's lifetime to meet their function needs. But ideally, the treatment should delay. Ideally, it should delay or stop, and sometimes it should reverse the damage to the optic nerve and ganglion cell caused by the glaucomatous process. You know, three important theory for glaucoma. That's one is the intraocular pressure I mentioned already. So most of the treatment goal is mainly to harness around the reduction in intraocular pressure. That's the one thing we are doing with most of the treatment. And the second thing is to increase the optic nerve purification. And third one is how to protect the retinal ganglion cell. This is also a very well known fact that we have to preserve the visual field. You know, with the lower IOP, definitely the visual field is preserved for a long time. If the IOP is very high, then you may go for visual field defect, and ultimately they will go for blindness. And this also Krishna is going to talk about in his talk also. And the fundamental goal is mainly to slow down the rate of the retinal ganglion cell. And of course, normally also, if there is age-related decay of the retinal ganglion cell, but that does not lead to much of optic nerve. Slightly over due course of time, they will have slight the cup, etc. But they will not go for any field defect or any blindness. But in glaucoma, if it is untreated, you know, drastically it will go for blindness in a short span of time. And if you treat it, you can prolong the visual function for quite a number of years, depending upon our level of treatment and the optic nerve changes. And the treatment, many treatments are available to reduce intraocular pressure, medical therapy, laser, cyclodextrin, etc. But each has got its own risk and benefits. Whichever method is chosen, it should be really predictable, safe, and easy for the patient to use. But unfortunately, there is no ideal treatment so far available for management of glaucoma. So these are some of the important principles that we have to follow, because it's not like just to see a pressure of 24 or just a deep cup or some black dots in the visual fields. We have to make sure the patient is having glaucoma. Just making accurate clinical diagnosis, the patient is having definite glaucoma. And you have to assess the stage of the disease and assess the risk factors for the disease progression, especially non-ocular risk factors we have to find out. And also another important thing, the socioeconomic and life expectancy. A patient with 85 years subjecting them to too much of investigation or loading them with so much of medication is not at all necessary. But at the same time, a man of 40 years, we have to do all the steps to preserve the visual field defects. So ideal medication should directly protect the optic nerve or reverse. But current option is the only way currently proven is to slow or damage the from progressing is to reduce the intraocular pressure. I already mentioned there is no other medication is available. The plan is mainly the manage all patients with the glaucoma, the goal, and preserve the visual function while maintaining the best possible quality of life. That is very, very important. We have to talk to the patient, what their profession, how they feel with the present vision, and what way is going to affect their field of vision and visual acuity, and what treatment is going to do. Otherwise, patient will go for, since it's a chronic disease, definitely it's going to affect the quality of life of the patient. And also achieving the goal by setting the target pressure is very, very essential in each and every case. And so, of course, there's so much of a definition is available for the target pressure. It's a range of intraocular pressure enough to limit the progression of the visual field loss to a rate that will preserve the visual function without affecting the quality of life. That is the definition for the target pressure. And the quality of life, there are so many factors that can affect the quality of life. Even the weird, if you say you are having glaucoma, it definitely will going to affect the psychological, have some sort of psychological impact, especially younger individuals. And also the chronicity is again another thing, potentially blinding what are the situations and side effects. This is one thing which makes the treatment is very, very difficult. So how asymptomatic patient, most of the patients are coming with the asymptomatic state. So we are making a asymptomatic patient into a symptomatic patient by instituting so many medical therapy. And also inconvenience. Definitely it is very, very inconvenient for their daily day-to-day life because the timing is and other things, everything. And loss of visual field of vision they lose, then they may have motility problem and other things. And the another important thing is the cost of treatment, especially in countries like us. That's all the factors that can affect the quality of life of the patients. So for an ophthalmologist, for us, the diagnosis and the initiation of treatment in glaucoma is straightforward. You are seeing the cupping, you are seeing the field effect, you are seeing the OCT changes, just straightforward. But however, a successful treatment can be difficult. This is very, very important. How to make the patient to comply to the treatment options whatever given to the patient. That's very, very important because it's not a conjunctivitis or not like cataract because patient has to use the drops for lifelong. So many factors are involved in that. So that I will come to it in short time. And of course, these are all the problems, with we are with all our medications, anything can happen. Patient can have a conjunctivitis or RD or depression with lipid bradycardia with beta blockers and cardiac with the rocket, anything. Because so many complications can happen. These are all things in day-to-day practice. So we should be aware of this, all these side effects. And also, teaching ophthalmology, we should need to know all these things about the drugs. We should we should not write down the prescription, especially the youngsters, fellows or PGs. We have to understand the drug pharmacology, mechanism of action and dose, contraindication, of course, and the side effects, interaction with the systemic drugs, and how to combine both two different classes of drugs and benefits and risks for the patient, and of course the cost of the drug. That's very, very, as I already mentioned, cost is very, very important, especially in our situation. And of course, it should be effective, time-tested, and it should be available through the thing. And before starting the initial treatment, these are certain things we have to ask from the patient, the history and risk factors about the certain other non-ocular diabetic hypertension, any other blood loss or migraine. All these things are very, very family history of glaucoma. Everything is very, very important. The history of allergy, systemic disease and treatment like beta blockers or any other thing or pacemaker, bypass, CAPG, and history of all these things, a detailed history. You should know about the history of the medical history of the patient, non-ocular medical history. So the choice of therapy depends upon the quality of life of the patient, the cost of medication, the compliance, whether the patient is able to use the drops regularly. That's very, very important. Then other systemic diseases like diabetes, hypertension, and the type of glaucoma. So not just to see the eye alone. So we have to see the patient as a whole. Then only we can give a sitting in a camp or sitting in a charity hospital, we cannot give a very expensive medication, which is very, very unreasonable or unpractical, not practical for the patient to follow the drugs. And make sure that it should have a long-term effective and safe for the patient, and the patient must be able to use the therapy continuously with the minimal side effect and also minimal effect on the quality of life of the patient. So for that, a good physician and patient relationship is very, very important because patient has to come to us throughout his life So every time you should not ask what is your name, and that type of, you have to know the patient in detail, his history, everything. That only the treatment will be very, very successful. Patient will come for the follow-up. If you treat them as a new patient every time, then the patient will lose the confidence on us. So we have to, part and parcel of the patient. Patient should realize that we are concerned about the health of the patient. So for that, we have to have a good communication about the disease. We have to tell them what is glaucoma and what treatment we are going to institute, what is the outcome, and also little side effect. That's very, very important. Suppose if you don't tell about the side effects, next day patient will come with the same bottle, 900 rupees spent. So I guess severe pain, what to do for that type of patient we used to get many times. Outcome. So expensive medication I used for so many years, the vision is same. I don't have any improvement in vision. So all these things we have to talk to them in advance. Otherwise, patient will not believe. If you tell them in later, when they come with the side effect, they will not believe. So we have to tell them in advance so that patient will make himself that, okay, doctor has told already about the side effects. And also, this is some of the important thing what is happening in glaucoma. We may diagnose glaucoma, we may give the drugs to the patient is using the drug. But what happened, one thing as I already mentioned, is not diagnosed, is or over or underdiagnosed. And the severity of glaucoma is underestimated. That another thing. And inadequate IOP control. The patient is using anti-glaucoma medication, but there is no follow-up, and also there is no follow-up of intraocular pressure measurement, how the IOP is getting controlled with the medication. So inadequate, and also undetected intraocular pressure spikes. That's also one of the important things for the progression of the disease. And also complaints. We have failed in asking about how many bottles you have used, or how many times you have not used applying the medication. All these things, you have to ask about the complaints is very, very important. So we have to check for the complaints of the disease. That's why a proper knowledge about the disease is not important to the patient. If it's not important to the patient, then all these things can happen. So we have to make sure the patient understood everything. Then, of course, the basic principles is all of you know very well about the sort of diagnosis, such a target pressure, baseline, then follow up, all these things. So, lastly, we have to take care of the quality of life of the patient. So, this is how we approach the patient. I am not going to detail how you have to diagnose that so many things are available. And when to initiate therapy, as I already mentioned, make sure that the patient is having glaucoma. If they are severe, then only you have to treat the patient. There is nothing wrong, or nothing will happen if you wait for a few days, a few weeks, or even for a few months. Make sure the patient is having glaucoma. And whenever the IOP is high enough to cause eventual loss of vision, and then third with progressive cupping and progressive visual field loss. These are the time we have to start the treatment. This first choice of treatment depends upon the patient characteristic and drug properties. And of course, it can be monotherapy or depend upon the stage of disease, combination therapy or polyform. It's more than 1 or 2 or 3 drugs we have to use to control the intraocular pressure. These are some of the practical, this unilateral we are not doing nowadays. Previously, it was done. And also encourage the lid closure, which I used to do most of the time in our patient. All the time, just ask them to pinch the nasal lacrimal duct for about 30 seconds. That will help to retain the medication in the eye for a long time. And also, you have to substitute, and all this educating the patient is very, very important, because we are giving drops for so many months, but we have never taught them how to use the drop. That's why we have to teach each and every patient is potentially they can go for blind. So we have to spend some time, or a counselor or staff nurse in the OPD, we have to teach them how to instill the drop, how to put the drop, where to put the drops, etc. That's very, very important. And target pressure, as I already mentioned, it's different for each person. and may change with the time also. For same patient, it may change with time. That's why you have to continuously reassess the target pressure. These are various definitions for target pressure. These are the various factors like the structural and functional damage, age, and baseline intraocular pressure, additional risk factors, etc. There are three methods way of estimating the target pressure. One is the threshold, like in terms of millimeter of mercury, how much you have to for severe, for early and mild, moderate glaucoma you have to reduce. And also the American Academy of Ophthalmology have come up with a simple guideline to classify glaucoma into 3 stages: mild, moderate, and severe. Is a very, mild cases, 20% reduction, moderate 30%, and severe 35 to 40. And what is mild, all these things are a little beyond for this one. And for advanced glaucoma, you have to low as much as possible. And also these are the formula based, which is not practically, it's not possible in the day-to-day practice, mainly for the studies. And this is a beautiful thing. I like it very much, because this is the middle one of the 5 factors we have to keep it in mind when you set the target pressure. One is the glaucoma damage, second life expectancy, and untreated baseline intraocular pressure, additional risk factors, and fifth one is the rate of progression. So depending upon that, suppose the early glaucoma, you just set a little higher target pressure, advanced glaucoma. So it's a very nice thing that we can, for European Glaucoma Society has given this guideline, but in a simple diagram they have given a beautiful how to this one. And after they said limitation for the target intraocular pressure. It's a no-fear fire method is not that great. And what also this, we do not know what aspect of intraocular pressure actually causes the damage. Whereas a peak intraocular pressure or fluctuation or short spikes. That's again another important thing we have to keep it in mind. And also the diurnal physiological variation and need to be reevaluated constantly. And of course the beta blockers, we normally use beta blockers as the first line, and depending upon the patient, the socioeconomic analysis, always will go for the prostaglandin as the first line of treatment. This it is also a famous this thing, which initial treatment. If it is responsive, you continue it. If it is unresponsive, you just change it to another medication. If it is not sufficient, you add some other drugs to control the intraocular pressure. Then compliance is again another important thing we have to keep it in mind. There are types of non-compliance. You know very well, our patients are so smart. They will like general medicine and other things. We have to overuse or improper timing and the use of wrong medication, self-medication. So many things happens there. And also the compliance decreases with the, we have to keep it in mind that the compliance definitely decreases with increasing frequency. Suppose if you give 3 or 4 drugs 2 times daily, one and once daily, then 4 times a day, then patient will get confused and they will lose interest in using medications. And also it decreases the increasing number of medications and also complex schedules between both eyes. Right eye different drugs and left eye different drugs and this and that. Then definitely patient will not be a good compliant patient. So these are the reasons for non-compliance, and a good compliance depends upon the, again, a good doctor-patient relationship and cooperation from the patient, awareness of the side effects, understanding the problem of what will happen if you don't use the drugs. And of course, a good patient counseling is very, very important in cases like chronic disease like glaucoma. And this also various complaints, how to improve the complaints of the patients. And of course, trabeculum dynamics, the common question the patient will ask, how many drops they have to use and how much gap between each drops. Usually we used to tell them that a single drop in the cul-de-sac is very, very essential. That's enough, more than enough. And of course, they have to multiple drops. What will happen? They will have systemic absorption or side effects will be more, and mostly they will do it by the nasolacrimal duct. So this also most of the people know very well. So one drop over the other, immediately the first one will be completely washed out, and you will have concomitant lessening of the effect of the first drug. 30-second interval, you will have 45% washout, and 2 minutes 17 and 5 minutes there is no washout. I used to tell them, you just give 10 minutes interval between the two drugs. If they are using two drugs, I will give the minimum 10 minutes for them to use the drugs. So immediately it's better not to use the second one. And also definitely nasal drug occlusion is very, very essential to keep we have a more efficacy. So finally, there are 5 questions must be answered. These are the 5 questions. What is the effect of glaucoma on patient's ability to work? There's a quality of life. We have to ask the patient and everything and understand the disease, both especially by the patient. We have to tell them and then how they understood what we have mentioned or explained to them. And of course, the side effects of treatment. And also the other things, as I already mentioned, compliance, adherence, and persistence, etc. Then cost of treatment, whether they will be able to use the drugs continuously because of the cost, or they will otherwise we have to modify the treatment, or we have to go for some other options, whether it's a laser or surgery. That's a thing we have to ask the patients. So take out the following points: the distance to the clinic from home to travel time and etc. Especially in countries like us, no patient cannot come for frequent follow. So how to reduce the follow, and there's a number of visits and ease of appointments. Patient, suppose the waiting time is more, or they have to wait for so many days for appointment, then they also the patient will lose the interest. And do the test judiciously to contain the cost. So frequent, depending upon the stage of the disease, we have to advise the necessary investigation. Not all the time, all the investigation is very, very costly for the patients. So to conclude, again, what I want to tell is glaucoma treatment is very, very easy, but we have to see the patient as a whole. We will see whether the patient is having definitely glaucoma, whether the patient will be able to use the drugs regularly, where they are able to afford to buy the drugs and etc. Generally, we have to start the treatment, or we have to go for some other options like laser or surgical, which will give you a permanent control of the intraocular pressure after explaining the merits and demerits of the procedure. Thank you. They are able to afford to buy the drugs and etc. Generally, thank you very much. Thank you very much. Sorry, I have exceeded my time, I think.
Thank you, sir. Thank you, RK sir. Wonderful to. Thank you, RK sir. It's a very elaborate and nice talk by you. And may I request Dr. Venkatesh to introduce Dr. Krishnadas sir, and then we'll have his talk. After that, we have our panel discussion. Over to you, Venkatesh.
Thank you. Thank you, Satyar, for organizing this very nice webinar where we are respecting all our past presidents. It was a pleasure listening to Professor Ramakrishnan. And now it's a pleasure to introduce my teacher and mentor, Dr. S.R. Krishnadas, who graduated from Hill Park Medical College, and later he did his residency program at Aravind Eye Hospital, Madurai. And since then, he has kind of seen several positions in Aravind, being a medical officer, a chief medical officer of Aravind Eye Hospital, Madurai. He has also led the human resource department, and at present, he is the director of fellowship and physician development program at Aravind Eye Care System, who really cares about every resident and fellow and consultant in the system now. So he's been an amazing teacher, because we have personally firsthand been his students who have listened to some of his great teaching over a period of time. And beyond that, he's a great researcher who was behind the Aravind, the comprehensive eye survey with Professor RK, and also the dose response study, which clearly gave us the dose for mitomycin. So these are some of the landmark work which he has done, but he is also placed his footprint in the Aravind Medical Research Foundation, doing a lot of basic science work with the scientists there, especially with Dr. Sundaresan on genetics and proteomics of glaucoma. And also he worked on a very innovative AI model with the triple IT team, finding out about early detection of glaucoma using fundus images, especially in low-cost cameras. So he has been really involved in a lot of good work, not only in glaucoma, but also in the field of ophthalmology. It's a pleasure to introduce Dr. Krishnadas, and the stage is open for him. Hello.
Are you able to connect?
Yeah, Satya. Oh, they are not there in line?
No, should be. Because both of them are sitting in the same place. So I think
Okay, we'll give them a second.
Devan, Murli, and Venkatesh, can you just in the meantime, can you just start some discussion so that they can join in?
Yeah, I think they are not connected. I think they've gone off the Zoom right now. Yeah, I think it was wonderful to listen to Dr. R.K. of more than 3 decades of experience of what glaucoma means to a patient and what it means to us to manage the glaucoma and so on. I think it's a really wonderful overview and a perspective. And I know having dealt with glaucoma patients for many, many years now, I think our concerns today are about how much technology we should use. Earlier, we used to have just a Schiartz tonometer and a direct ophthalmoscope and just a slit lamp to diagnose glaucoma. Now we are sort of overwhelmed with the technology, and we have so much of instrumentation and equipment and so on. With this background, I think we should have a clear take-home message for our practitioners and ourselves as to what should be the minimum which we should have for us to say or to use to say somebody has glaucoma. Should we have every available technology, corneal thickness and ASOCT and high-tech OCT imaging of the RNFL and macula, or should we just stick with basics like intraocular pressure measurement, absolute indications for having a disc picture and so on? Technology is something worrying because it increases the cost of the management of the patient. And the second, of course, is some of these, many of the glaucomas are underdiagnosed, and some of our glaucomas are over-treated. I think Dr. R.K. was clearly mentioning that. These are some of the serious concerns that face us in our day-to-day practice. So I think we should probably address this as we discuss things along. Maybe I invite Dr. Satyan and Dr. Venkatesh and Dr. Sood as well to share their thoughts on where technology is actually bothering us and how much should we use technology.
So I think the talk was very concise and very well put together. My first question, Murli, coming from what you have said is, what is important in glaucoma diagnosis and management? A clinical examination or the use of technology?
Absolutely. So I think from my perspective, I think the rock bottom, the bare essential would be evaluating the patient on a slit lamp, measuring the intraocular pressure with an appellation tonometer, having a gonioscopy to see the angle, and of course have a good optic disc evaluation. There is no cutting corners on this data we need. And of course, so when you suspect somebody with a raised intraocular pressure and a normal looking disc, that's when I think the corneal thickness and the measurements become very important. This is absolutely the bottom line. Over and above this, we need to see how the patient is actually being affected by the glaucoma in terms of the function, that is the visual field. And then when you suspect something more and we want to follow up and we have additional technology like OCT, we can use OCT judiciously, not to diagnose glaucoma, but maybe in a suspect or ocular hypertensive, we want to look at some early changes in the structure. Maybe you could start using OCTs. So we now see the OCT as being overused and almost like the It seems like OCT, without an OCT, we cannot practice glaucoma. So that's what I would like to dispel the notion that OCT is not absolutely essential for the diagnosis of glaucoma. Definitely for a glaucoma practitioner or a glaucoma practice, I think we do need technology. But the message we need to convey to our practitioners is that we need things like intraocular pressure, gonioscopy, and a disc evaluation as the absolute bottom line.
So Murli, can I take this in another way and ask, I mean, this is to all the other panelists, does every raised pressure, does every pressure more than 21 millimeters of mercury need to be treated?
Yeah, when we can discuss this because Dr. Krishnadas is ready, I think.
Sure.
Yes, sir. Dr. Krishna, sir, you can take it forward. Yeah, I briefly introduced you, but we lost your connection.
It's important in glaucoma diagnosis and management. A clinical examination or the use of technology?
Absolutely. So I think from my perspective, I think the rock bottom, the bare essential would be evaluating the patient on a slit lamp, measuring the intraocular pressure with an appellation tonometer, having a gonioscopy to see the angle, and have a good optic disc evaluation. There is no cutting. This data we need. And of course, so when you suspect somebody with a raised intraocular pressure and a normal looking disc, that's when I think the corneal thickness and the measurements become very important. This is absolutely the bottom line. Over and above this, we need to see how
is it getting repeated?
In terms of the function, there's visual field. And then when you suspect something more and we want to follow up and we have additional
I think it's replaying the previous discussion.
But maybe in a suspect or ocular hypertensive, we want to look at some early changes in the structure. Maybe you could start using OCTs. So we now see the OCT as being sort of being overused and almost like the, it seems like OCT, without an OCT, we cannot practice glaucoma. So that's what I would like to do. Dr. Krishnadas, please start your talk. Yeah. Request you to start your talk.
Yeah, just a minute. Is my slide seen?
Oh, yes, sir. You can go to the.
Now we can see, and then you can just make it as a full page. Yeah.
Okay.
Yeah.
Really extremely sorry for this technical snag. I did something that cut off the original connection. Thank you, Venkatesh. I heard at least partly your generous introduction. Thank you very much. And I would like to congratulate Satyan and our senior colleagues for choosing such complementary topics. Dr. RK speaking about the initial management and asking me to talk about the emerging treatment paradigms in glaucoma. So the whole idea of this topic is to challenge Dr. RK's suggestion of initial management of glaucoma as medical therapy, which has been the conventional mode of treating. So this is just an initial slide. That's actually a study done in Italy, in a tertiary eye care center in Italy, that in the past 1 decade, what has been the characteristics of patients receiving their first glaucoma surgeries. Over this 10 or 11 years, what has been noticed in this study is that patients undergoing first glaucoma surgeries are increasingly younger age. They tend to have lower intraocular pressures, which means that there is a lower threshold for choosing patients for glaucoma surgery. And the grading of glaucoma was found to be of lesser and lesser severity as the decade passed by. And the most common surgeries that have been performed for glaucoma has been predominantly minimally invasive surgery. So that sort of summarizes what is the thinking in the glaucoma fraternity about the evolving treatment of glaucoma, which has been changing in the past 1 decade. And this has been similar in studies from Europe and the United States. Of course, we do not have such statistics for what has been happening in India, but I can increasingly see that increasingly initial treatment for open angle glaucoma is being SLT, and initial surgery for open angle glaucoma and even for primary angle closure, as we can see later, tends to be angle surgeries, which comes under the category of minimally invasive surgery. So Dr. RK did show a similar slide which showed the rate of progression of glaucoma, but this is a classical graph on rate of progression described by Joseph Caprioli in the year 2008, which seems to demonstrate that if we tend to intervene early, the likelihood of preserving vision and the visual field tends to be better, rather than when we intervene late, when the visual dysfunction tends to still deteriorate over a period of time. So the whole thing is, how do we intervene early by interventional glaucoma, which is the watchword now, which we shall see shortly, what we mean by interventional glaucoma. So the current treatment algorithm, which was actually partly covered by Dr. RK, is the initial monotherapy, followed by stepped up maximum tolerated medical therapy. Of course, in case of angle closure, it's preceded by LPI, followed by SLT to supplement medical therapy. And then when disease still progresses, we go on for guarded filtering procedures when target intraocular pressures are not reached. So what ails the current treatment option? Of course, this was again elaborately led by Dr. RK, who was talking about the ocular and systemic adverse events, the ocular surface disease problems, poor adherence, and of course, long-term medical treatment can compromise surgical outcomes when done later. And we need to understand the law of diminishing returns, where therapeutic efficacy of medications diminishes over a period of time. Surgical treatment of glaucoma, the major advantage of surgery is that the IUP control tends to be more consistent with less of intraocular pressure fluctuations, which actually helps in preserving the vision better than huge fluctuations in intraocular pressure. And this is, of course, independent of patient-related factors like adherence in management of glaucoma. It does reduce medication burden, delays progression, with better vision preservation, and major advantage of surgical management is the long-term cost effectiveness as compared to medical treatment. Now, talking about primary surgical treatment versus medical therapy, we have the CIGET study, which is a randomized comparison of initial treatment as surgery and medications. And some of the learnings from this study is that there is no differences in quality of life or visual outcomes in 5 years. And primary surgery group did have lower intraocular pressure, but it came with a caveat that cataract progression was higher and complications were, of course, higher because of the surgical intervention. At 5 years, the mean visual function on visual field was comparable between the two groups. What the CIGET's group recommended was to go in for individualized tailoring of treatment by treating ophthalmologists, and they indirectly said just continue the conventional treatment of medical, laser, and then glaucoma filtering surgery. And of course, we do not prefer primary surgery, especially surgeries like tubes or traps, because of the fear of sight-threatening complications. And guarded filtering procedures are not necessarily safe. They have delayed visual recovery, and close post-operative monitoring is required to modify the bleb as well as the consequent intraocular pressure, and of course, sight-threatening complications, including hypotony and post-operative endophthalmitis. Now, what is the problem with the traditional treatment algorithms is that it is stepwise and it's a reactive approach. Meaning you start with one medication as mentioned by Dr. RK, and then you find the disease progressive, add another medication. And again, if intraocular pressures are not controlled or disease progressive, we add 3 or 4 medications and so on, until you let the patient earn his surgery after significant progression of disease, and which we can term as glaucoma surgery at almost very advanced glaucoma, which we can term as end-stage glaucoma surgery. So such medication-first approach has several limitations because of progressive glaucoma and many of those followed up on medications. A fifth become blind and at least in one eye in 2 decades. And of course, non-adherence with medications is a significant factor in progressive visual loss. Medications fail to attenuate the IOP fluctuations as much as laser treatment or surgeries do. And again, as we saw from Sujat's, many studies are there to say that surgical interventions tend to preserve visual function better. So what is this evolving interventional glaucoma paradigm that we are talking about? Is it tends to advocate earlier procedural intervention. Procedural may be laser or a minimally invasive surgery or even trabeculectomy if you feel it is safer. And I would not like to cover about the newer drug delivery systems with the long-acting travoprost and bimatoprost, which have been introduced in the Western world. One thing, it's very expensive and it is not available for us in India, so we will not talk more about it. We will talk more our propensity towards a fundamentally a proactive approach to managing glaucoma, which means we will initially use a procedure rather than medical treatment. We want to be conservative and we say we will try laser trabeculoplasty first with add-on medications and when necessary. And if glaucoma is either suspected to be progressive on OCT rather than on visual fields, or intraocular pressures are far above target, we tend to go in for less invasive, minimally invasive procedures like the angle surgeries. So again, these approach, kind of proactive interventional approach, tends to achieve and maintain intraocular pressure in modest acceptable range. And intervention at the earliest stage, as we had seen earlier, tends to prevent progression of glaucoma and delay or avoid high-risk glaucoma surgeries because number of surgeries that is required after SLT or an angle surgery like GAT or KDB is much, much less compared to those following medical management. And these procedural interventions also decrease reliance on patient adherence with reduced medication burden and more cost effectiveness. And option of more invasive surgeries is always available for us when glaucoma tends to be progressive after these initial procedural treatments are considered. So the whole thing is such an approach will reset our dependence on patient adherence as the main reason for preserving vision in glaucoma or making glaucoma a stable condition. So these are some of the alternative approaches. We will focus more on initial SLT versus medications and on minimally invasive glaucoma surgeries. So we know that SLT through various mechanisms tends to increase the trabecular aqueous outflow. And the merits are that it can be safe, it can be repeated several times. Of course, with repetitions, efficacy tends to decrease. Proven efficacy of SLT compared to medications. Medication adherence or adverse events due to medications are of course obviated. There is reduced medication dependence even if additional supplemental medical treatment is required, and medication burden and cost can be further reduced. No major adverse events like what we have in medical treatment or penetrating glaucoma surgeries. So these are some of the, one is the LIGHT trial. I may not have much time to elaborate on that, but there is a review of ophthalmic technology assessment from the American Academy of Ophthalmology recently published last year, which recommends SLT as initial therapy even prior to a trial of stepped up medical treatment. So the LIGHT trial, the summary is 6-year results is there is lesser visual field progression in the SLT group and a higher eye drop free intraocular pressure control with the need for lesser medications to control IOP at target And the need for glaucoma filtering surgery also in the initial SLT group is much less significant compared to the medication first group. And it can be repeated to increase its efficacy. So this is an editorial from the BJO, which says due to the trials and the studies conducted from the West and the US, whether SLT should be considered as an initial management of choice in developing countries of Asia and Africa. And of course, we all know the increasing role of cataract surgery in primary angle closure disease, in early primary angle closure glaucoma, or in primary angle closure suspects, or primary angle closure. Cataract extraction in the presence of visually debilitating cataracts could be a wonderful way of widening the angle, eliminating pupillary block, and preventing further progressive angle closure glaucoma. So mild to, who are suited for MIGS, angle surgeries, mild to moderate glaucoma, those intolerant to medical therapy, poor adherence, target IOP is not achieved by SLT, and a visually significant cataract and medically controlled glaucoma can also be considered for combined MIGS and cataract surgery. And in instances where penetrating surgery can be considered as a high risk. So we will not go into the details of MIGS. In this forum, we have dealt with many speakers, esteemed speakers, talking about MIGS, showing a lot of videos. So for lack of time, I will not go into it. Let us come to the MIGS not only in open angles, even in angle closure glaucoma. Increasingly published studies are saying that goniocyclosis of peripheral anterior synechiae combined with one of the angle surgeries, be it KDB, Tenito hook, micro hook trabeculotomy, or GAD, can have very good results, even in eyes with advanced angle closure glaucoma. I will not talk about non-penetrating surgery, glaucoma surgery, because the relevance of NPGS has actually decreased following the advent of minimally invasive surgeries. And just to add about cyclophotocoagulation, in eyes in which glaucoma filtering surgery could be at a high risk, or if angle surgery is not feasible, endocyclophotocoagulation where available, or even transscleral diodes cyclophotocoagulation could be a good either initial or supplementary treatment in eyes with advanced angle closure glaucoma. To summarize, we need to ensure that trabeculectomy is not forgotten. We need to ensure the younger generation is not overemphasizing on the importance and significance of MIGS, so that we need to ensure that we train our younger generation even in the older guarded filtration techniques. So trabeculectomy continues to play a pivotal role in managing glaucomas. It addresses all aspects of outflow obstruction, including distal collector channels, the raised episcleral venous pressure, and so on. And it can be the primary option in glaucomas where the anterior chamber angle cannot be accessed even after goniocyclosis. So again, I will not talk about the future directions. It's only potential therapies that are possible in the next decade due to gene therapy and stem cell therapy, nanomedicine, and neuroprotection. Many of them are investigational and not proved to be successful in human subjects. So in summary, there is currently persuasive evidence for SLT as initial treatment for glaucoma, open angle glaucoma. Safer, effective alternatives to guarded filtration procedures for managing glaucoma are evolving. And we can now assertively say that MIGS can be offered a safe alternative to trabeculectomy in mild to moderate glaucoma, often in conjunction with the cataract surgeries. And from experience, I would even say, I don't have any published evidence for this, that even in eyes with advanced open angle glaucomas, advanced angle closure glaucomas, MIGS could be given a try. And trabeculectomy, we need to understand and remember that it continues to play a very significant role and is a good fallback option when MIGS and other primary modality of therapy do not help in halting the progression of glaucoma. So I would like to acknowledge my colleagues who had shared their videos, which I have not shown for lack of time, and a very special gratitude to Dr. Devinder Grover I think he was probably largely responsible for bringing MIX to India with his training of doctors in Pondicherry and elsewhere. With that, I will end the lecture. Thank you very much for the patient listening and my late arrival. And yes, panelists, we can have questions. We have 1 minute, but probably we can take the next 5 to 10 minutes for some questions.
Yes, Deven, Murli, and Venkatesh. And of course, we have our secretary, and of course, we have our treasurer too to join for the discussion.
Yeah. Satyan, it's not a question now, but whenever I use, there's some echo. அங்க ரெண்டு can you mute, sir? Krishnadas, sir?
Yeah.
Okay.
So I still remember, no, in my early days when I joined ophthalmology, when I used to ask RK, what is the best option for glaucoma? He says glaucoma is a surgical disease. No? So because those days we were seeing glaucoma in a very advanced stage, and there is no point in doing, giving them a medicine or changing medicine or doing laser. So most of the time when we see glaucoma in an outreach patient, especially when you screen for cataract, you find advanced cupping. No, we go for we think that it's a surgical disease. But now when you listen to Krishnadas talk, the whole paradigm has changed. Now, whatever stage the glaucoma is now, it looks like it's a surgical disease where it needs some kind of intervention beyond medical therapy, which would improve the quality of life and the quality of vision and the life for the patient for a long time. And that is what we see in our practice also. Over a period of time when we change therapy and make them come back for review, we slowly see some of them decline, some of them being stable, but most of them also decline. So I think we have to, there's a very strong message, at least from both the talks, that compliance is so difficult. So we need to consider at this point of time something to do early, give those options early to them. And that's what I thought was the biggest message in today's discussion. Yeah.
So let me come back and add a little more to this and ask, is there, do you, Dr. Krishnadas and Dr. Ramakrishna, do you find a change in the patient's perception and acceptance of surgery early in the course of the disease, looking at your 3 decades of experience with glaucoma patients?
Yeah, very good question, sir.
It's a good question, Dev. And previously, we were also a little reluctant to advise surgery in early stages of glaucoma, because at that time we didn't have much option except for the partial thickness, the trabeculectomy, which patient definitely, it's very difficult to satisfy the patient after surgery, at least for a few months. But now with the advent of all these newer angle surgeries, etc., I think because we can, there is a scope for the early intervention in early stage of glaucoma. That's what I feel. Yeah.
Are the patient willing, sir? Like how we do early?
Yeah, definitely. Yeah. If they are off drugs, definitely. Yeah. That's what the change in now. Otherwise, patient is aware that glaucoma, they have to use the drugs lifelong, something like that, and also the progression and this thing. Suppose if you tell them and if you are able to get good result with MIX and no need for further medication, there will not be any further progression of the disease process, then patient's acceptance is very, very good.
Sure. Just to add to this, the kind of patients we are now seeing, we still see in the elderly age group. We are still not diagnosing glaucoma early. All this paradigm changes we are talking about in treatment has not been translated into early detection of glaucoma.
So whatever,
yeah, that is right. When the patients come, they are already in their 50s, 60s with fairly moderate to advanced glaucoma and cataracts. So when we have patients with cataract with some defect in vision, and when you suggest a primary treatment, they are readily agree. The most challenge to us comes from younger individuals 45 and less, who present with early onset open angle or juvenile glaucoma, who have very clear lenses. And definitely there is no compulsion for us to remove these lenses. So we need to go in for standalone MIGS.
Yeah, we are doing it.
Yes. But I do not know if standalone MIGS are giving as much effective IOP lowering as combined MIGS with cataracts. I stand corrected on that. But some evidence is there to see that when MIGS is combined with cataract, the IOP lowering is far more additional. Of course, more extensive angle surgeries like GAT, even standalone GAT have effective IOP lowering. The most problem with GAT is, of course, the increased incidence of IFEMA. That's a major concern, which actually we hesitate to consider GAT. And recently listening to Devinder, he says in these situations, it is better to switch to hemi-GAT, where part of the angle is 180 or, part of the angle is excised. And he says it's as effective as 360-degree GAT, and the frequency of IFEMA is far less. So yes, right. We can advise surgery earlier in the stage of the disease. Only thing, we need to be well versed in angle surgery, standalone angle surgeries.
Thank you for both your wonderful presentations and the discussion. And over to RK sir, and both of you, of course, and other panel members also. How often you feel the SLT is more effective? Manish, you are being in Mumbai. I'm sure that you may be doing SLTs also. I just want to know how much SLT has been really used as a primary therapy in our current practice, especially considering the in POAG. All of you can give your comments, because this is going to be a game changer from just starting on medication.
No, I think my personal experience with SLT has been very encouraging, and I have been advising. But as RK sir said, a patient is wanting that if the intervention is done, it should make him free of drops. Unfortunately, SLT in the initial stages is able to deliver that for a few years. But MIGS, even standalone or even combined with cataract surgery, I am not in a position to assure the patient that you will be free of drops. And only thing is, definitely patients who are having intolerance or side effects to drops are very open to getting something done. But patients who have tried drops and are not suffering from very severe side effects aren't so open to interventions. And when I was a beginner, at least this is in the last 10 years, I haven't had this problem. But before that, I used to have this problem, even convincing a patient who has frank appositional angle closure with glaucoma changes to get an iridotomy done. Moment I advised an iridotomy, the patient went to take second opinion, third opinion, and usually went to people who did not do gonioscopy and just said, oh, you put drops, you will be fine. So interventions patients are ready for only if they are going to see the straight benefit, and then only in glaucoma the straight benefit they want to see is being free of drops, which unfortunately in the current scenario MIGS is not able to offer, in my experience at least. So I would like to know from more experienced people, Venkatesh especially, who is a leader in MIGS, whether he has this experience of patients being free of drops after MIGS.
Yeah, well,
Manish,
you can.
Vignesh?
No, you can go for it. Yeah.
No, that was the thought we are also having when we initially we were a little skeptical about doing MIGS for advanced glaucoma, open this angle closure glaucoma. But in our experience, we are doing most of the advanced glaucoma also, and angle closure with high intraocular pressure, with high. There is a drastic reduction in the intraocular pressure. At least I'm seeing for the past 2 years, the follow-up is very much encouraging. It's Sometimes they will come for single digits and not more than 20. Only few cases, I don't know which case going for failure. Maybe about 10% of the cases they may need medication. Most of them are off medications. So the IOP reduction is very good in cases with high intraocular pressure. That's what I am seeing in our patients. What Venkatesh, what do you feel?
No, like Manish is asking about mild, moderate, and severe. Definitely severe with several medications, like maximum tolerable medication.
Yeah.
You can't guarantee them. But what we are seeing now, at least in moderate glaucoma, if they are on one or two, I still tell them that you may need one medication, but definitely we can reduce your medications. I can't make it nil, but many of the time we see some good results. We are able to wean them off or even totally remove, or maybe add one medication after some time. So this happens in now mild to moderate glaucomas, where you are trying to combine cataract with glaucoma, like what Krishnadas said. See, standalone, still we are not able to really comment. Now, how is the impact of, can we really guarantee them that you can be medication free? No, like how you do an SLT and say, I can remove this medicine off. If this works, we are not really confident to say, because standalone GART is not that easy. When you have a lens there, it's not very easy. And again, several of cases, especially in high myopes, we have seen these kind of intractable hyphemas, at least in one or two in our experience, which has been nagging behind us. So we are very careful in young patients, especially in juvenile glaucomas, to do 360 degrees. So we are preferring the 180 degrees. But I'm pretty confident, at least patients on two medications, we still say them that we can get rid of your medications. If not both, at least one. If you are on one, definitely yes. So that guarantee we are able to give these patients. And more importantly, we are seeing a kind of change in the post-operative protocol. Patients are comfortable, eye is more wide. You don't have to frequently follow up like the trabeculectomy. All those advantages which we see, and now just by doing like a cataract, you can add on this. And we are seeing those advantages to the patients. And also as a provider, our chat time, all that reduces, because you don't have to convince them about bleb or sutural lysis and things like that. But you may have to do certain things post-op, but not as aggressively like how we do trabeculectomy. So that saves time for both. It also reduces the travel of the patients, the frequent follow-ups, and several other costs related to that. And that is a major change which we are seeing now after at least doing MIGS in the last 3-4 years.
Thank you Venkatesh, for your comments.
Can I come and ask something, Satya?
Yeah, please, Devan. Yeah.
So this question is both to Venkatesh and Dr. Krishnadas and Dr. Ramakrishna. Earlier, we were operating to prevent disease progression. Are we now performing glaucoma surgery to reduce the number of drops and patient convenience?
Partly, yes, Devan. Murli, can you answer that?
Yeah, I think I've been just so absorbed in listening to all of you that I think I'm quite surprised at Dr. Krishnadas' talk about the changing paradigm, which I am actually finding for the last several years now. There's an increasing acceptance of SLT, at least in our practice. And initially, when I offer SLT to somebody maybe 10 years ago, they were taking it, 1 in 10 patients would take it. Now, almost 5 out of 10, almost half the patients accept SLT now. And I offer SLT as a routine, and acceptance has increased. The second about the MIGS.
Murli, there could be a regional or a geographical variation in acceptance, because I think the panelists and the speakers are skewed to southern India. In northern India, the trend is still to say, when we get a procedure done, we want the result to be achieved. And if there is a need for drops or there is an increase in the pressure, it is considered as failure of the procedure and the treating doctor. So this trend is still going to persist in northern India. So I think all of you from southern India are very vehement in the acceptance and the results. So I would like to ask Manish, my question is more on acceptance, because actually, I have the advantage of now listening to probably 2 or 3 generations of people here. And I'm more interested in seeing what is the change that is happening from the times that Dr. Krishnadas and Dr. RK have been treating to the time when Venkatesh, Murli have been treating in southern India, and comparing that with West and probably the North Indian trend, because that will give us a larger perspective.
I think before Dr. RK speaks, I think this north-south trend between treatments and even maybe including Manish in the west of India, I think it's not really that different. We do treat patients actually from north of India. We get a lot of patients from east of India. In Chennai, we get a lot of people from other than Tamil Nadu. So I don't really think there's a difference in the response of the patients to treatment, at least in our Indian scenario. I'm not sure if the others will agree with me. I think it's more of maybe the acceptance of treatment and maybe the protocols and the technology which is being used, the correct technology for the correct patient and so on. But I do find that SLT is definitely has a place in my practice. And also the MIGS has really taken off in a big way, at least in our practices. And we do reserve the traps only for the patients in whom we're literally up against the wall. We don't really have anything else to offer as a mix. I don't do that much of GAT, but I do mostly the Tanito, the KDB, and a bit of the iStents as well. And in patients who are using, say, 3 drops, who probably needed more than that, and the mixed procedures definitely reduces the need for multiple medication. And answering Manish's question about are they completely drop-free? Probably no. And maybe for some patients, say the mild to moderates, probably they are completely off the drops. In some occasional patient, you probably need maybe 1 medication. So that is probably far better than having a dysesthetic bleb, having a dysfunctional bleb, doing multiple needlings and suture removals, and like Venkatesh was pointing out, the discomfort of having a bleb and putting in, coming for frequent follow-ups. The mix has really gone far ahead, and definitely it's a paradigm change. And I think we do have to accept that we should look at the mix as a game changer in glaucoma management.
Yeah, we will soon have a detailed discussions about the mix and the future talks as well. So because we really do not have much of a time, we would like to really respect all our audience. Actually, the series goes like this: 20, 20, 20. The talks is for 20 minutes and the discussion for 20 minutes. As it is a first meeting, we have just exceeded our time because of the little bit of a technical things as the first meeting. So we'll just make sure that everything goes on very smoothly. So at this point, I would like to request Dr. Manish, our secretary, to say thanks to all the people, and then whatever the other information from the GSI. Over to you, Manish.
So
I think the 20 seems to be a glaucoma number. So pressure exceeding 20, the time exceeding 20. I think we have also exceeded the time by 20 today, by the way.
Yeah. I'm
So
sure we
that
can
seems
keep
to be very
discussing, but
auspicious that
unfortunately we
going
don't have
by 20.
time.
So thank you very much for very excellent eye-opening talks by both the stalwarts, Dr. RK and Dr. Krishnadas. They're really stimulating talks and stimulating the brains and to think further and to challenges to be seen in the future. And of course, our panelists, Dr. Murli, Dr. Devan, and Krishna and Venkatesh have really given us fantastic inputs. And I think it was an academic feast, the first presidential session that we are having for the Glaucoma Society of India. And I'm really grateful to the president, Dr. Satyan, for organizing this whole event, and to all of you for sparing time and participating actively. So thank you very much, all of us, and look forward to future activities of the Glaucoma Society of India. We are getting our act in order, and you will see more of the presidentials every month, as Satyan has said, and we plan to introduce foreign speakers also. That will be a separate session, and some other competitions, photo competitions, quiz competitions online, and try to get maximum involvement of all the sections of the Glaucoma Society. Try not to leave anyone behind. Let us all enjoy the academic fest all together everywhere. Thank you very much and good night.
Thank you, Manish. Just
Thank you very much, everyone.
information is on February 25th, we will be having our guest speaker, Dr. Kahuk.
Great.
So we'll have it on 25th. of February. Thank you. Thank you
Thank
so
you.
much, all of you, and
Thank you, GSI.
meet you
Executive.
soon. Thank you
Very
all.
stimulating. Look
Okay.
forward
Yes.
to more.
Thanks.
Thank you very much, Satyan.
Thank
Very
you.
well organized. Everyone.
Thank you.
Thank
Thank
you.
you all.
Thank you.
Okay. Bye-bye.
See you.
Good night.
See you in Bhopal.
Yeah.